So thanks everybody for joining us on this Monday afternoon here on the East Coast. If you're joining us from across the country, thanks for taking the time in the morning here to spend some time with us. We're going to be talking about advanced heart failure. We've got Dr. Anu Lala from Mount Sinai. Dr. Lala is an associate professor at the Icahn School of Medicine at Mount Sinai. She's also the program director of their Advanced Heart Failure and Transplant Cardiology Fellowship, and probably well known to most of us, she's also the deputy editor of the Journal of Cardiac Failure, which is the journal of the Heart Failure Society of America. So she wears a lot of hats and a lot of different roles and does a great job at all of them. And I'm really excited to see what she has for us today when she's going to be talking about advanced heart failure. So Dr. Lala, thank you so much. And please go ahead and take it away.
Oh, thanks, Mike, so much. And thank you to those of you who are joining and listening in various capacities at different times. It's really, I think this lecture series is exactly what our community broadly needs. And so I'm very grateful to you for spearheading this effort. And I'm very excited to be included to continue to see it grow and blossom over the years. So I have the daunting task of talking about the recognition of advanced heart failure, which is a pretty elusive topic. It's also a very spanning topic, but I'll do my best to cover whatever we can in this half an hour, and then I'd be happy to be contacted and discuss more, and I can share my email and my social media information at the end of the talk, so feel free to reach out to me. My relevant disclosures, let's see if it will, there we go. I think Dr. Beasley already mentioned my love for the Journal of Failure. You'll see a lot of great references pertaining to this topic in this talk. So over the next 25 minutes or so, I want to talk about how the landscape of advanced heart failure is larger than what we really think it is. And this talk is very much geared towards you, the advanced heart failure fellow. I think how and when to define advanced heart failure are in evolution. And I think there's some really exciting developments in this space over the past several years and to come. I would say if you're going to get anything out of this talk, I really, really would push to objectify functional capacity in your patients. I think that is the greatest thing that we can do to be able to help risk stratify patients. If we had to just hang on one specific test or movement in this space. I, as always, will touch on something that's near and dear to my heart, which is how much words matter when we communicate with our patients and with each other. And then I'll just end with a concept of how much medical and device-based therapies are actually understudied in this advanced heart failure population. Okay, so let's start out with the question, and you can obviously just think for yourself as to what the right answer might be here. Which of the following patients has advanced heart failure? Is it A, a 63-year-old man with TTR cardiac amyloid, an EF of 60%, severe LVH, elevated filling pressures, a reduced cardiac index, atrial fibrillation, who has dyspnea, walking? Is it B, a 40-year-old woman with a type in-related dilated cardiomyopathy, an EF of 15%, an end diastolic dimension of 7 centimeters, who's unable to walk across the street, buy groceries due to shortness of breath? Is it C, a 55-year-old man with hypertrophic cardiomyopathy, an EF of 70%, who's experienced cardiac arrest twice and is currently in VT storm? Or is it D, an 80-year-old woman with an ischemic cardiomyopathy, an ejection fraction of 20%, who is on home milrinone? Or is it E, all of the above? And I would argue that all of these patients have what we would call advanced heart failure. So I think we're in such an exciting period in our field because the umbrella of entities and disease processes that fall under advanced heart failure is ever expanding, right? We now have dilated cardiomyopathies, which was a part of it, but now severe functional MR really isn't. It's really heart failure, right? And now overlapping with interventional. Cardiogenic shock, temporary circulatory support overlaps and falls under the umbrella of advanced heart failure. Inotropes, of course, treating advanced end-stage heart failure. Mechanical circulatory support always been under this umbrella. Transplantation, of course. but also palliative care, understanding goals of care, personalizing care. Heart failure with preserved ejection fraction. This also now falls under the umbrella of advanced heart failure with PH, even in some circumstances without PH. Chronic amyloid has seen so much advancements as has hypertrophic cardiomyopathy. So really all of those entities fall under this umbrella. So then how it comes to the point where how do we really define advanced heart failure? Where has it been defined and how is it evolving with time? We're all familiar the staging system of heart failure that has evolved since the new universal definition in JCF in 2021 to the latest guidelines in JCF 2022 with stage A, who are those at risk, stage B with pre-heart failure, and then the stage C, the symptomatic heart failure, going into the advanced heart failure, which is the stage D folks, right? These are people who typically we've been told and taught are refractory to conventional medical therapy and require consideration of advanced therapies, which include mechanical circulatory support and or transplantation, and potentially supportive cardiology or palliative care. And then this overlaps with the intermax profile system, really where marked limitations are experienced with normal activity, her symptomatic at rest. It kind of overlaps with all of the different profiles. But more recently, what we've realized is that there's this kind of in-between stage that is being called, has already been coined, quite frankly, the C2D stage. And we'll talk a little bit more about this stage, which is you're not quite at the point where you require transplantation and or durable MCS, but you're being hospitalized frequently. You have sort of the end stages of stage C heart failure, right? And so this is the field, this is the space that we're trying to better define with time. I say we are all familiar with this algorithm called I need help. This is a really nice way, 9 signs that can remind us of things that signify advanced heart failure, right? One, and I want to be clear here. I want to make sure that when we speak with our general cardiology colleagues or other colleagues, primary physicians and clinicians, it's not that they need help, it's the patient needs help. The patient requires an escalated consideration of care. So the I represents a need for inotropes. The N is New York Heart Association class 4 or symptoms at rest. So this is focused on the symptom. E, the first E is end organ dysfunction. So elevation in LFTs, elevation in creatinine. The second E is an ejection fraction that's particularly reduced. This is 20%, which is what's been published, but also less than 25% applies. D is for defibrillator shocks. The H represents recurrent heart failure hospitalizations. E, again, is escalating diuretic doses. The L is for low blood. E is for progressive intolerance of guideline-directed medical therapy. Another way of looking at all of these, again, seen in our most recent guidelines, repeated hospitalization. So you might say, well, what do you mean? How many do you mean specifically? 2 or more in the past 1 year. And this is not just hospitalizations, but also urgent heart failure visits, ER visits, even urgent clinic visits that may represent acute decompensation. We all across the spectrum. Low blood pressure was the L in HELP, right? Less than 90 millimeters of persistent dyspnea with dressing or bathing. I find this to be a really helpful question that's actually included in the KCCQ, where you ask, when you're washing your hair, are you really short of breath, or do you feel like you need someone to help you get your shirts on, buttoning your shirts, etc. An inability to walk 1 block on level ground, recent escalation of diuretics, that's the third E in HELP. And then this one that's not included is decline in serum sodium. I think that this is a real hallmark sign of advanced heart failure. We talked about frequent ICD shocks and need for inotropes. But just a minute here on these feel and function signs. I think they cannot be emphasized enough. We're going to come back to them, so hold on to that thought. So that's how we define advanced heart failure. But the when is also kind of elusive, right? We're all familiar with this classic paradigm that Lynn Warner Stevenson put together with Akshay Desai now over 10 years ago, where the challenge with heart failure is that the course is often unpredictable. Over a period of time, of course, there's this slow decline. However, what happens is that there's a lot of peaks and troughs. And so when you reach a trough, a quote unquote low point, you've been hospitalized, and then you get back to a much better status where you're less symptomatic, you're not necessarily aware of the fact that that new normal is worse than the normal before you were in the hospital or before you had decompensated. And eventually those peaks and troughs become more frequent, and then we sort of identify people as transitioning to a period of advanced heart failure where the decompensations are more frequent. Yet, there's no perfect number, right? It's based on the signs that I shared in the preceding 2 slides. And it's when we experience them in the chronic setting that we should be able to evaluate these. Another challenge in defining advanced heart failure lies on the fact that there's so much overlap with other conditions, right? Increasing age, you see more fatigue, you see more debility, you see more frailty. Where does advanced heart failure frailty and frailty associated with older age start, end? What about comorbid conditions, which we know our patients living with heart failure all have many of? What about cognitive impairment, how that overlaps with age, with comorbid conditions and heart failure? All of this is somewhat elusive, right? Nonetheless, I would say that the common theme to all of these issues is that there is, by virtue of having many comorbid conditions, advanced age, frailty, or cognitive impairment, is a limit in physiologic reserve. And I want to drive this point home because I think that this is really telling, even as we understand heart and how it evolves over time. When you have limited reserve, you have an increased vulnerability to adverse outcomes. And so I think this concept is one that I would like to put forth more and more. As the reserve diminishes, the heart failure is essentially more advanced or vice versa, and then you're more vulnerable to having an adverse outcome. So to that point, let's go back old school and think about how the stages of heart failure have actually evolved over time, right? This was beautiful work done by Carl Weber and colleagues. This is now 40 years old, where he said, okay, I'm going to take patients, this was heart failure with reduced ejection fraction, and I'm going to classify them based on what they're able to do, objectified based on cardiopulmonary exercise testing. Stage A were those people who did not have a restriction really in their functional capacity. And then as the stages progressed, they had lower and lower functional capacity as dictated by peak oxygen consumption, such that you can see that those folks who were labeled or classified or categorized in stage D were those people who couldn't even do more than, 3 METs really. So they were really, really symptomatic. Now he took those same individuals and he said, I'm going to put you in the cath lab and see how your hemodynamics correlate with your functional capacity and see if that offers more insight. And so what we know is that with exercise, we should be able to essentially multiply our cardiac output by up to 5 times, right? What we see here is the limit in cardiac reserve that I was trying to relay in a few slides ago. So let's look at, stage B individuals. These are people with mildly reduced functional capacity. They have a resting cardiac index that's a little bit diminished, but really with exercise, they're not able to augment and multiply it by 4 or 5 times. Their resting LV-EDP may or may not be normal, and then you can see a pretty pronounced increase with exercise. But as the functional capacity decreases, C and D, you see that the resting index decreases, fine. However, look at the augmentation with exercise and how much more limited that is, right? Here we were able to at least triple our cardiac index, and now we're able to just do a little bit more than double. As we're more restricted or limited in functional capacity, we're not even able to double our cardiac index. And look at our resting hemodynamics. markedly elevated LVEDP that goes up tremendously with exercise, and even more pronounced in those patients who are categorized as stage D. So there's a correspondence here. All of which to say is, as we advance in the stages of heart failure, we have more and more limited cardiac reserve. Okay, so along the lines of that, when, this is the real tough $1 million, billion-dollar question, right? Is, okay, we've talked a little bit about how to define it. We've talked about when to define it, although that remains somewhat elusive. But let's say we're basing that on the frequency and all the frequency of urgent visits, as well as the other signs that we shared already. And then it's, when do we quote unquote pull the trigger to proceed to transplant, to durable mechanical circulatory support, or even a consideration of palliation? So there's no perfect timing, obviously, but what we're seeking to really figure out is, we don't want to refer patients too early when they're too well. We don't want to refer them when they're too sick, such that they may not be able to derive benefit from the advanced therapy that we're leading them towards. So the sweet spot is trying to get at the optimal timing, which, if we look at Intermax profiles, has fallen somewhere between this 3 and 4 range, where you may be stable on inotropes, or Intermax 4, which represents this NYHA class 4 patient who is symptomatic at rest, or with even just minimal exertion, potentially may be under consideration for inotropes. And then, what are the different reasons that patients may not be deemed appropriate for advanced therapies? Oftentimes we'll hear this in our field: so-and-so was referred for advanced therapies, but they were not deemed to be a candidate, right? Either they were too sick, there were psychosocial concerns, they were too well, patient declined, or there was an underlying malignancy or comorbid condition that was considered to be prohibitive. A word here on how much our words matter. I would say that this word candidate or candidacy, I think, is problematic. We often see this scenario: Mr. X is not a candidate for transplantation due to XYZ. But if we change that wording to really represent what it is that we're seeking to convey, it's more like this: it's Mr. X is unlikely to derive benefit from heart transplantation at this time due to active colon cancer. Immediately, I have a context. I understand why or why not this person would not derive benefit from transplantation. That's the whole purpose. Whereas on the left, we see candidacy alone without more of context really kind of can come off as judgmental. Similarly, we might see a scenario like Miss Y is not a candidate for LVAD due to XYZ. Or we could say Miss Y is unlikely to derive benefit at this time from LVAD implantation due to prior stroke, severe peripheral vascular disease, and recurrent gastrointestinal bleeding. So again, we're able to say, oh, because of those factors, she likely will not derive benefit from LVAD. Or, and then that can be further quantified or qualified. Again, just pointing out that candidacy alone may sound judgmental. It may actually set up our patients for defensiveness and opposition, and it really clouds personalized context. Whereas when we talk about benefit to be derived from an advanced therapy, the focus is on the intention of the therapy. It's a setup for better patient-clinician communication, and it allows for focus on actionable issues. So Mr. X, for example, may be reconsidered for transplantation once he's 5 years free of that colon cancer, as an example. Okay, so coming back to really the landscape of advanced heart failure, I would argue, and many of us have said this, that we're myopic in this situation. We really need to know more about the broader heart failure population who don't go on to having LVAD or transplant, right? Really, what we see, or what we know in terms of research, what's published, what's talked about, is all about the heart transplant and LVAD recipients, right? That's where you get the news stories. That's where there's new innovations, et cetera. But we don't know much about those patients who are referred but don't go on to have those therapies. And then what about the ambulatory advanced heart failure population? We don't know enough about that. And in response to that calling or gap in knowledge, the NHLBI actually put together a work group last year, and we're amidst publishing a number of consensus documents based on that workshop, whereby we're seeking to put out a call to action for our broader community to better understand this ambulatory advanced heart failure population that may fit some of those signs and symptoms, but may not necessarily need durable MCS and or transplantation at this particular time. This broader group, you can kind of think about this diagram better kind of representing what actually happens, right? I would argue a smaller proportion of those with advanced, and this is just heart failure with reduced ejection fraction for simplicity's sake, are referred for advanced therapies, evaluated for advanced therapies, and then even a minority of those patients are actually go on to being listed or getting an MCS. And then a small proportion may be on a palliative inotrope or undergo palliative care. But what about this population who's not referred? How many of them go on to die? And what do we know about that population? What about this population that goes on to have disease progression? When are they referred? When do they circle back? We don't know enough about this, and we need to respond to that call and that gap. You know, one study that really sought to better understand this population was the Revival cohort. This was a registry of advanced heart failure patients, and I can share with you what we used to define this population. It was 400 patients nationwide, NHLBI sponsored, and these were individuals with elevated natriuretic peptides, low serum sodium, poor prognosis based on the Seattle heart failure model or heart failure survival score. And I would ask you to look into that. It's sort of beyond what we're able to cover in this 30-minute talk. But these scores are now almost 25 plus years older. And what has been found with the Seattle heart failure model is that it actually may underrepresent risk. I think it's a wonderful exercise to put characteristics into these models because it helps you understand what may or may not change as a result of different factors in these models. And then the heart failure survival score, especially when incorporating functional capacity, which one of my mentors really helped put on the heart failure map, Dr. Donna Mancini, can actually be very helpful, which all goes to emphasize this next point, which is low peak VO2, understanding the importance of functional capacity, or a high VEVCO2 or ventilatory efficiency slope, and a short 6-minute walk distance. So objectifying functional capacity, as well as more than 2 heart failure hospitalizations in the prior year. That's how they defined individuals, or we defined individuals to enter the Revival cohort. We subsequently did an analysis of understanding functional capacity and cardiopulmonary exercise testing. We did all of those tests here. We at Mount Sinai served as the core lab to oversee those tests rather, so that they were all kind of uniformly assessed and interpreted by Dr. Mancini and our group. And what we found in this study was that there were 3 things that were really, really prognostically important. Peak VO2, of course, it has panned out time and time again as being prognostically significant, less than 14, with a beta blocker less than 12. But also ventilatory efficiency, and that's that VEVCO2 slope, which I think is really important, especially in those patients who had submaximal effort or who had a respiratory exchange ratio that was less than 1. I think that's important because oftentimes we do these cardiopulmonary exercise tests and someone will have a submaximal effort, their RER was 0.9, and then their VO2 or peak VO2 rather was 12. And you say, well, what if they had gone further? Maybe they could have done more and their peak VO2 would have been higher and then they may not need a transplant. And so in that scenario, the VEVCO2 slope can be extremely helpful. So above 35 being prognostically significant. Maximal effort tests, circulatory power was actually found to be really important there as well, taking that peak VO2 into account, multiplying it by the blood pressure. And then Borg scale, I found this to be a really surprising and interesting finding in this study that we did, which is the patient's perception of how hard it was to do that test was prognostically important, which again underscores if the patient is telling you they feel terrible, we have to listen to it, which underscores KCCQ, which underscores, our patients telling us about their daily lives and how they may or may not feel limited in it, being very prognostically important and a marker of advanced heart failure. I want to take a second just to mention the importance of cognitive impairment and its overlap with heart failure as well. And this is also a really kind of elusive area. There's a beautiful scientific statement put forth by the HFSA. This was led by Iran Gordeski in Cleveland, that really helps us understand that cognitive impairment, of course, can happen as a result of non-cardiovascular causes, age, diabetes, chronic kidney disease, mood disorders, sleep disorders, et cetera. But heart failure-related cognitive impairment, of course, can be due to cerebral hypoperfusion, flow dysregulation. And so there's this really important overlap. Really, I would say at the end is just for us to objectify it. Just the way we need to objectify our functional capacity, we need to objectify cognitive impairment and do that routinely in our patient. So screening is really the name of the game, I think, here. And then thereafter, we're able to kind of tease out whether it's a marker of advanced heart failure alone or whether it may be mitigated by specific targeted treatments. I would also argue that we need to better understand medical therapy in advanced heart failure in general. This is a beautiful state-of-the-art paper published by Adam DeVore and colleagues in JCF that just looks at the proportion of patients with NYHA class 4 in all of our heart failure trials, and it's really none of them. Look at them. The only two that have focused on advanced heart failure are Consensus, right, now 30 years old, and the LIFE trial of sacubitril valsartan versus valsartan. We'll touch on that in a slide or two. Or rather, we'll touch on it right now. Sorry. This was the LIFE trial that I was very proud to participate in as well. And this was 167 patients randomized to sacubitril valsartan versus 108 in valsartan. And interestingly enough, there was no difference between the two with respect to lowering NT-proBNP levels. And that was the primary endpoint, as we know. We saw that with Pioneer and others to be a surrogate for clinical endpoints. And this was rather surprising. I think, yes, you can comment on that there were a numerically higher number of days alive and out of hospital and free from heart failure events, but not in the sacubitril valsartan group, but rather in the valsartan group. And so the question really arises, like, here is this population too advanced to really derive benefit from sacubitril valsartan? Was the blood pressure prohibitive for these individuals? And so it just speaks to the importance for us to systematically study these patients with advanced symptoms such that we don't extrapolate from other trials to what is potentially a distinct patient population. Similarly, you can look at vericiguat, and for that matter, omecamtiv mecarbil, which I haven't included for the sake of time here. What we have to look at is residual risk. Look at the risk here of dying at 12 months. You're looking at 30 to 35%. And so this speaks to this beautiful brief report that was put forth by Muthu Vadugunathan and colleagues, which is like if you compare ASCVD risk and the risk for advanced heart failure as we approach this top end of the bar, we're off the charts, right? In terms of what is your risk for clinical outcomes. So the need to better define this space is critical. And so what I always say to fellows is when you're looking at these Kaplan-Meier curves, look at the residual risk. The same applies if you look at the TRANSFORM study. Look at the area under this curve. How many patients, even if they are benefiting from the therapy that is under question or under study, there's still so much residual risk for us to mitigate. That's also representative of the advanced heart failure population. I would say, a couple of other things that always come up in this field is inotropes here. Are they really that bad? We're conventionally, we are taught and we understand that it increases myocardial oxygen consumption, thereby they're deleterious, they're associated with increases in mortality in clinical trials. But more modern collection of data, albeit subject to confounding, really showed no difference in survival amongst an advanced heart failure population, but rather potential for improvement in feel and function outcomes. So this warrants sort of separate designated study. I also like to mention this device space because it's really exploding. If you look at the COAP data, which was published at presented at TCT rather several years ago, and then the 5-year data was published subsequently. When we talk about residual risk, my goodness, these patients at 5-year, 91% of them experienced death or hospitalizations versus 74% in the MitraClip group. This is an incredibly advanced population that can really represent an advanced heart failure population. So I would argue that here, I think we need to think about device-based therapies, not only when you're refractory to medical therapy, but rather in tandem. It's never or, it's and that shift in thinking is something that I have just kind of experienced in more recent years. There's a beautiful scientific statement led by Jerry Estep and Marat Foudim in JCF, just published last week, that I would encourage you to look at on behalf of the HFSA, just talking about the wide array of device-based therapies that can apply to our patients with advanced heart failure and even not such advanced heart failure. So I would say increasingly, we need to approach advanced heart failure across a continuum rather than waiting for this bucket saying, okay, you are refractory to medical therapy, thereby you're advanced heart failure, and now you need to get a VAD or a transplant. Rather, I think there's signs and symptoms that can be appreciated across the continuum, across LVEF, across functional capacity, and across both acute and chronic presentations. I think these 3 continua are really important for us to keep in mind. And thereby, we can have clear definitions, allow for distinct phenotypes to be appreciated, and then tailor our medicine accordingly so that our medicine and our therapies accordingly so that therapies can be delivered in an equitable fashion, and we can implement in a personalized and equitable fashion. So in that, I'll end in our last minute with the advanced heart failure landscape is very broad, and it's underappreciated and kind of under-recognized or underreported, rather understudied. A large population of these patients, like I said, are under-identified and understudied. If you can get one thing, like I said in the beginning, is let's objectify functional capacity, because time and time again, that has pointed out the limitations in cardiac reserve that signify the advanced heart failure population. And we really have such a need to better study these populations to inform optimal medical and device-based therapy. So I want to thank you so much for your attention, and thank you, Dr. Beasley, for your spearheading this effort. I can take any questions.
Thanks, Dr. Lala. That was a really great talk, and I always learn a lot from your writing and your talks. And I like the words matter focus that you've had in the past. I've really taken that to heart, and the way I phrase my my documentation these days. And this new concept of C to D, I think that's really interesting, because that's kind of I feel like a lot of patients, I'm not really sure wherever to put them, and I liked how you had introduced that concept early in the talk here, because that was brand new to me. So thank you so much. Anybody out there in the group that has any questions for Dr. Lala, you're welcome to unmute yourselves or ask a question at this time. If there's nobody there, the question I had was, I practice in a part of one of my clinics is in a part of Connecticut where we don't have great access to cardiopulmonary exercise testing. So, and I think this idea of objectifying people's symptom burden and trying to really identify where they're at in that continuum makes a lot of sense to me. So what would you recommend, in somebody like myself or somebody, practicing elsewhere that doesn't have cardiopulmonary exercise testing available locally for patients to kind of help do that for them?
Yeah, thanks so much, Mike. I think that's such an important point, because by no means do we only have to rest our hands on cardiopulmonary exercise testing. 6-minute walk testing has actually been shown to be incredibly helpful. 300 meters has corresponded to a peak of 14 in multiple studies. I think it's just a matter of real kind of, and you may say, 6-minute walk testing is is subject to, inconsistencies and variability, et cetera. But it is still an objective measure. It is still what we use to qualify patients. And I think what's been really heartwarming for me to see, and we actually use 6-minute walk distance for many of our revival patients who actually couldn't go on to have cardiopulmonary exercise testing. Only 270 some odd patients of the 400 had reproducible data and were able to show up for CPETs, et cetera. So we did a lot of 6-minute walk distance testing. And to me, what was so striking is that you have a patient coming in being like, yeah, I'm fine, I'm okay. Unless you really probe, you may not really uncover the fact that they have a limited reserve. And then when you walk them in the hallways with that measuring tape, say, my goodness, wow, your 6-minute walk distance was only 240 meters, or you know what I mean? And so I think it's really telling for us as clinicians to see what our patients are like when they are walking. And I think it's also very telling for the patients themselves. The other part I'll just say is that objective testing also offers the patient to comment on the difficulty he or she or they experience while they are doing that objective walking for you. And again, as we found in the revival study, that Borg scale representing difficulty is also prognostically important.
Thank you. Thank you. Any questions out there from the rest of the attendees? Well, if not, we're a little bit past the hour. So Dr. Lala, thank you again so much for joining. Look forward to hopefully running into you in Atlanta, HFSA, just around the corner. And for everybody else, thanks for taking the time. We'll be back next week with Dr. Clark talking about non-invasive imaging in heart failure. Thanks so much.